Good evening. My name is Kristen Austin, and today I will be presenting the prevention of ventilator associated pneumonia, which is also known as VAMP. I also had the pleasure to work with Erin Page and Kim Booth. I know some of you are asking, what is a ventilator? Well, a ventilator is a machine that helps a patient breathe when they stop breathing. A lot of people call it life support or the breathing machine, where you have a tube down your throat that helps the air gets down into your lungs and helps you breathe. Um, Within the first 48 hours of being intubated and ventilated, you are more acceptable of getting pneumonia. Pneumonia is the second most common hospital infection in the United States and is also associated with substantial morbidity and 13 to 55% of mortality. Pneumonia accounts for approximately 11% to 15% of hospital associated infections and 27% to 24% of all infections acquired in the medical intensive care, also known as MICU, and the coronary care units, known as CCU, which increases ICU stays for several days and hospital stays up to 1 to 3 weeks. All of this information came from the CDC and also from the IHI.org. In order to start this plan, we must have goals. Our first goal will be to decrease the rate of VAMP by 50% within 9 months and achieve a rate of zero point 0.0 to 1,000 ventilator days by December the 31st, 2019. We also will want to decrease the amount of days spent on the ventilator in ICUs. And by doing this, we should by working on this problem, we will reduce the amount of VAMP in the units. The most two important things is making sure that we save the hospital millions of dollars and protect our patients from any kind of infectious diseases. I have gone around and observed several units, and I have found that nurses and respiratory therapists are breaking the vent circuits during suctioning instead of using the closed circuit ballard to suction. Water from the heater are not being drained properly. They are draining back into the reservoir, which causes bacteria it causes patients to breathe back bacteria through the ventilator. And also some of the rain out is draining into the ET tubes, causing aspiration. We also need to make sure that we keep the head of the bed elevated 35 to 45 degrees. The most major factor that is standing in our way of improving this situation is education. We must enforce education for all our staff members. There will be surveys conducted. There will be surveys conducted to evaluate both nursing staff and respiratory staff. The first plan that we should use should be the ventilator bundle plan. It consists of elevating head of bed 30 to 45 degrees, oral care every 8 hours, use of a subglottic secretion drainage, ET tube, daily suctioning, daily sedation interpretation, and assessing readiness for extubation to get them off the ventilator. We also need to avoid scheduling vent circuits, changing out the vent circuits on a day-to-day basis. Have certain days where we do it so we can decrease the times that we break the circuit away from the patient to ventilator. The next few slides are just going to kind of elaborate on each one of the topics that I just talked about. This is some of the evidence of the head of the bed, the various reasons why we want to keep the head of the bed at least 35 at least 35 to 45 degrees. It helps with aspiration. Aspiration causes pneumonia, and we want to make sure that our patients are sitting up properly so that we won't have this kind of pneumonia infection going on. There has been a study of 277 patients requiring mechanical ventilation that were supine, which is laying flat, and it increased the chances of getting pneumonia. The second slide just shows you the oral care kits, what the nurses will have to use to clean out the mouth every 8 hours. The next slide is a picture of the subglottic ET tube that suctions the secretions in the back of the throat, which helps with infection because a lot of bacteria sitting behind the ET tube, it causes infections and causes pneumonia. So this is something that we would need to invest in. The next one is about the sedation vacation. Checking to wean the patient, see if the patient is ready to wean off sedation, so we can schedule a time to wean the patient off the vent. Next is measuring the things we need to use to measure the progress in our plan. The rate of ventilator-associated pneumonias per 1,000 patient ventilator days in patients in intensive care units as measured by the Centers of Disease Control and Prevention. Next, we will measure the accomplishments, the AIM percentage of intensive care patients on mechanical ventilation. Make sure that they all have the ventilation bundle documented completely and properly. We need to collect the baseline rates of the ICU and hospital length of stay, mortality for mechanical ventilation, patients in the units by using daily care process data. Chart audits will be ran daily, at least twice a shift, making sure that everybody is compliant with documenting the ventilator bundle plans. In conclusion, the system and the process design, we need to focus on the system and the process design, enforce training for every nursing and respiratory staff. Also need to train our doctors to put the orders in correctly. We got to train all the staff members and the physicians on the standard practice and the tools to assist adhering to these standard practices. We must implement the entire ventilator bundle to result in significantly better outcomes than any of the elements of the bundle implemented independently. I hope you enjoyed my presentation, and this concludes it.